Hello, good evening, everybody. Are you able to see the screen? Hello? Hello?
Yes, sir.
Yeah, okay. So I think we'll start. Good evening, Dr. Sunil Bandesti. Nice. So today we'll be dealing with recent advances in secondary stroke prevention. So this is a very important topic. So many advances have taken place in the last couple of years, which have added to our armamentarium, and we should know the recent trials which have brought out these results. So that's the main idea of this thing. So what we do is we introduce the topic, and we discuss acute interventions for secondary prevention, which DAPT, and how we treat stuttering strokes and capsular warning syndromes, and the stroke with atrial fibrillation. What are the recent studies on these three aspects of acute stroke phase secondary prevention? And then we'll discuss about chronic phase stroke with atrial fibrillation and percutaneous left atrial appendage occlusion, small vessel vascular disease, and prevention in strokes secondary to cervical artery dissection, and ICAD, intracranial atherosclerotic disease, ECAD, ESUS, and the common theme of all the secondary prevention is the vascular risk factors management, which we'll discuss. Then we'll shift our gaze towards the ICH and interstitial hemorrhage and what we are supposed to do in the acute stage, and we'll conclude the talk. So this is the scheme which we'll address, we'll follow this time. And you know that 2021, there's a American Heart Association and ASA guidelines have come for prevention of stroke in patients with stroke and TIS. And everybody should refer to these guidelines. And some of these important points we're going to mention in my recommendations. So first of all, you should know the stroke subtypes, and we all know that ischemic stroke constitutes about 88%. In intracranial or intracerebral hemorrhage is 10%, subarachnoid hemorrhage is 2%. In the ischemic category, you have non-lacunar strokes about 77%. Out of these, 35% are cardioembolic, 17% are large artery, 45% are cryptogenic, and others are 3%. The other group is the lacunar strokes and cryptogenic, ESUS 50%, non-ESUS 50%. That's how we divide these stroke subtypes. And why ischemic stroke recurrence? We should have the risk awareness and how highlighting the risk of recurrence, and that's around 26%. It causes increased burden, increased mortality and morbidity, increased costs. So focus on targeted therapies to prevent the stroke recurrence. Just will briefly elaborate on this. You can see in this ECAD, ICAD, and cardioembolic strokes lacunar cryptogenic, 30-day recurrence 9%, 8% like that, 1 year 11%, and 5 years also the recurrence is there. So this is in Manhattan study. But important point to remember is 23% of all ischemic strokes are recurrent events. The recurrent stroke increases mortality, morbidity, and costs. The pooled cumulative stroke recurrence risk with percentages and 95% confidence intervals are seen. The point to note is even after 10 years, the recurrence is there, and the recurrence in 30 days is 3.1%, and 1 year 11, and over 5 years 26, and 10 years 41. That means we have to ensure that secondary preventive strategies are carried almost lifelong once a stroke occurs. And these strokes can be because of many reasons. The cumulative risk of stroke recurrence is shown in this graph, and it goes on increasing over the years. So there is no respite of the preventive therapies. You have to go on taking preventive therapies, as the 10-year risk also is very high. So the main armamentarium what we have is oral antiplatelet therapies. These are aspirin COX-1 inhibitor, which decreases thromboxane A2. The phosphodiesterase inhibitor, that is dipyridamole, which increases the cytosol GMP and inhibits thromboxane synthase and decreases uptake of adenosine, that is dipyridamole. Then clopidogrel, P2Y12 receptor antagonist, which decreases ADP, and it has got a prodrug, and it is subjected to P450 system activation. That causes again a problem of resistance. And ticagrelor, which is also a P2Y12 receptor antagonist, which decreases ADP, but it is reversible and direct acting. There is no prodrug here. And cilostazol, the phosphodiesterase 3 inhibitor, increases the AMP, cyclic AMP. And there are others like ticlopidine, prasugrel, and others which are not very less popular, but they are there. So these are the various mechanisms. All of you know. We're not going to discuss much of this. Then we have the oral anticoagulants, the vitamin K antagonists, the inhibitors of factors 2, 7, 9, 10, and requires INR monitoring. The direct oral anticoagulants, DOACs, dabigatran, which is a direct thrombin inhibitor, that is 2A inhibitor. Apixaban, rivaroxaban, endoxaban, the direct factor 10A inhibitors. You can see how the tissue factor and 7A and the platelets are phase. And this is the warfarin that can act on various places. And rivaroxaban, apixaban, endoxaban is on factor 10A, and dabigatran as direct thrombin inhibitor. So these are the armamentarium with which we work. So next part, we'll see what is an acute phase, secondary prevention of acute phase. Single antiplatelet therapies we used to give initially before the thrombolytic therapy came. That's the only thing which we had. And then we started thrombolytic therapies. Now, over the course of decades, we adopted the approach of DAPT, which we are going to discuss a lot. So if antiplatelets, most important is aspirin. 2022 Cochrane review has given a detailed account of all this and what is its effectiveness and how much to be given, what is the dose, 160 to 300 milligrams, to be started within 48 hours of onset. But if you look at, for every 1,000 treated with aspirin, 13 avoided death or dependency, and numbers needed to benefit is 79. So that's what we had before the NINS trial came, and it has some side effects and symptomatic ICH, and major extracranial hemorrhage also is seen. Then the combinations, and there are important studies which I have listed here. The second European stroke prevention study, that is ESPS2, which said ASA and dipyridamole are slightly more effective than aspirin alone. So we started using this combination. This study was started within 3 months of stroke, and it's a very large study, 6,000 plus. And the stroke recurrence rate is 9.5% in the combination therapy versus aspirin, 12.5%. Then European Australian stroke prevention in reversible ischemic trial, that is eSpirit trial, has shown that slightly more effective versus ASS. This is also again another important study. But then PROFESS trial came, which was published in New England Journal of Medicine in 2008, which studied clopidogrel versus this combination, which showed no difference. So the ASA and dipyridamole combination is will you please mute? So this is an important study which PROFESS trial has shown with combination with clopidogrel. But we have all used this combination, but it has got a lot of GI side effects, ASF plus dipyridamole. Then came the Capri study, clopidogrel, which has studied with aspirin, and that said there is no difference. And 7.2% risk reduction of vascular death and stroke and MI. Then MATCH trial, in which the TIA or ischemic stroke within 3 months, clopidogrel plus aspirin versus clopidogrel placebo was studied, and there was no difference. But there is slightly increased the hemorrhage in these cases. Then ticagrelor was studied in way back in 2012, and there is also no difference when compared to clopidogrel. So that's how, before a decade back, what we were thinking about all these studies and all these antiplatelet agents. Then the things started changing because we started analyzing these trials very much. Then these three important trials have come. That is important. Initially was FASTER, which I didn't show here. The CHANCE, which is a Chinese trial, and the POINT, which is a European trial, which are published in New England Journal of Medicine. In that, what is shown is aspirin plus clopidogrel is superior to aspirin alone, with no increased risk of bleeding, with some caveats which have been analyzed, and I'll give you the recommendation later. And the POINT trial is also said that it is superior to, the combination is superior to aspirin, but higher risk of bleeding. So when is this risk of bleeding? So we can analyze that and give a recommendation. And the third one is ticagrelor, that is a Thales trial, which was published in 2020, almost in the COVID time. And it said that aspirin plus ticagrelor is superior to aspirin alone, but higher risk of bleeding. So all these trials have shown higher risk of bleeding. But then when we analyze this, all these things have very good effect, all these three trials. And summary of the landmark trials favoring DAPT to reduce recurrence of stroke in the earlier phase. And what is the recommendation? So you can see there is a BMG review, which was published by the clinical practice guideline after studying all the trials. And I also joined, I was also given a chance to work with Kameshwar Prasad sir and Gordon Guyot and all. I can see my name here as a stroke neurologist. And what this recommendation gave is that people with high risk transient ischemic attack and minor ischemic stroke are at increased risk of recurrent stroke and death. Aspirin and clopidogrel, they decrease this risk even more so when used in combination. So what we made is a strong recommendation for DAPT with clopidogrel and aspirin to be started within 24 hours in patients who have had a high risk transient ischemic attack or minor stroke. No, you have to CHA2DS2, quote, you have to see and then assess the high risk category. We make a strong recommendation for DAPT to be continued for 10 to 21 days at least, at which point patient should continue with aspirin alone. So DAPT is not to be used for major strokes because of the increased risk of intracranial bleeding in these patients. So we get a lot of these cases of minor strokes and TIAs, and they are to be started with DAPT. And you see, when we did this recommendation 2020, that was 24 hours. Then what is latest is we got these three trials of non-cardioembolic strokes, that is ARAMIS, this is published in JAMA in 2023, ATAMIS, JAMA 2024, INSPIRE NEJM 2023. What do they say? In patients with non-disabling minor acute ischemic stroke within 4.5 hours, DAPT was non-inferior to IV alteplase for excellent 90-day functional outcome. That is JAMA 2023 RMS. So there is no difference for minor strokes whether you treat with DAPT or IV alteplase. The second one is another important thing. Here, the NIH stroke scale is 4 to 10. In patients with mild to moderate ischemic stroke, DAPT outperformed aspirin alone in reducing early neurological deterioration at 7 days with a similar safety profile. So now from minor strokes, we have graduated. If there is no thrombolytic therapy, we started giving this. Then the time limit also has increased in the INSPIRE trial. So here, the mild ischemic stroke or high-risk TIA of atherosclerotic origin, aspirin and clopidogrel started within 72 hours, reduced the risk of stroke recurrence at 90 days as compared to aspirin alone, but slightly increased risk of mild to moderate bleeding. So the time window has been extended from 24 hours, 48 hours, or 72 hours. So these are the three important landmark trials that have happened in the last 2 years. So most of these the recurrent strokes are more common with atherosclerotic origin subtypes. When we see the subtypes, we'll see, and when we saw that, so you should be giving these therapies in those cases. No, this is an important study that has come because clopidogrel it requires a prodrug which requires CYP2C19 activation, and there are many genetic polymorphisms, 10 to 30% or slow metabolizers, and this is higher in Asian populations. And nobody has studied this in India, so we don't know. But we use clopidogrel with impunity, and plus aspirin ticagrelor. So reversible, direct-acting, twice-daily dosing ticagrelor. So there's a study which is called CHANCE-2 study, which has shown that the ticagrelor plus aspirin 21 days versus clopidogrel versus aspirin 21 days, the 90-day stroke recurrence and severe bleeding, they are all favorable outcomes. So because clopidogrel has this problem in India, or that is the clopidogrel resistance, and most of them now prefer aspirin with ticagrelor as mostly the intervention neurologists, neuroradiologists, they prefer after CHANCE-2 trial. So what happened is patient education and counseling play a vital role in promoting team adherence and term adherence, and that is the how much you have to give at what intervals you give, and regular monitoring and adherence to prescribed therapies are essential components. So the time trends, the CHANCE trial, point trial, and AHR, you can see that the DAPT are started using, but it's not still in widespread use. So because these strategies have to be incorporated in your practice and start treating with DAPT only for up to 10 to 21 days. So that is one part. The second part of the acute is stuttering strokes. Stuttering strokes, they are small vessel disease. The infarcts and the distal distribution of deep penetrating vessels is lenticulostriate, Thilamon, pontine perforating, also recurrent artery of Hubner and anterior choroid artery. All these things are small arteries. And in the small stuttering strokes, what happens is these vessels go into a, a type of spasm, and that spasm gives rise to small strokes and a penumbra also. There is a oligemic zone there, and these are about 25% of all the ischemic strokes and less than 15 mm in diameter and subcortical. They also have recurrence to 4 to 11%, small vessel disease. These are the small vessel disease which you can see in the diagram. So some small subcortical infarcts cause transient fluctuating motor sensory deficits. These are about 3 episodes in 24 hours. They are about 60% risk of developing permanent debilitating deficits. The optimal treatment for preventing stroke progression is these lacunes is unclear. So, but these things keep happening. They are subcortical infarcts and they can be anywhere. And this rescue BT study, NAGM 2023, it has shown that acute ischemic stroke patients without large vessel occlusion or medium vessel occlusion and NIHs more than 5 within 24 hours and they are not eligible for IVT within 24 to 96 hours and progressive symptoms, early neurological deterioration after IVT also, 73% had penetrating artery disease. So that's what is important. So all these categories, they have penetrating artery disease. These arteries will go into spasms. So here IV tirofiban, 48 hours versus aspirin plus aspirin alone has shown that there is a benefit of 29% versus 22% relative risk reduction, 1.26. And there is slightly increased symptomatic intracerebral hemorrhage. So tirofiban it's a fast-acting, selective, short half-life group 2B3A receptor inhibitor. So it should be studied. It should be studied, and it has been studied by Dr. Vijay et al. From Guntur. And tirofiban is an IV antiplatelet drug, which is a group 2B3A inhibitor. It's useful in non-LVO and non-cardioembolic strokes beyond 4.5 hours in the scenario of capsular warning syndromes and progressing stroke associated with ICAD. So these abstracts have been presented International Stroke Conference in 2021 and also in 2022 use of intravenous trevofurine. So we have been seeing these abstracts which are published in International Journal of Stroke, and the latest one in October in this 2023 also there is one more same combination of IV tirofiban with aspirin in patients of AIS beyond 4.5 hours without large vessel occlusion. And now this year, this 2025 January, the abstract on this effect of tirofiban on 90-day functional outcomes in patients with presumed non-embolic strokes have got an award. This abstract was recognized as the highest ranked abstract at ISC 2025, and this was Paul Dudley White International Scholar Award is given to Dr. Vijaya and the colleagues who have studied this. So that means tirofiban is here to stay, and we have to use, and there are more number of studies are required to do, but it's useful to use in certain certain peculiar situations where you keep getting episodes within 24-hour period. So that part is over now. Initiation of anticoagulation after stroke. After stroke, when do you start? And what are the studies that have guided us so far? Balance have to be made with the risk of recurrent stroke with the risk of bleeding complications. The timing of anticoagulation initiation depends on several factors, including the severity of the stroke, the presence of hemorrhagic transformation, and the patient's overall risk profile. So these factors you have to study. And ELAN trial has provided crucial guidance on initiating anticoagulation after acute ischemic stroke in patients with AF, atrial fibrillation. This trial investigated the optimal timing for starting anticoagulation to minimize the risk of recurrent stroke while avoiding bleeding complications. So initiation of anticoagulation after ischemic stroke has been divided into two categories: early anticoagulation studied in about 1,000 patients, later anticoagulation 1,000 patients almost, that is ischemic stroke related to atrial fibrillation. The minor stroke, 48 hours later they started, moderate stroke also 48 hours, major stroke 6 to 7 days. And later anticoagulation, they defined minor stroke, they started after 3 to 4 days, not 2 days, 3 to 4 days, moderate 6 to 7, and major stroke 12 to 14. So there are no major safety concerns. So early anticoagulation is safe and beneficial. So we can stick to this recommendation of minor stroke to start 48 hours, moderate 48 hours, and major 6 to 7 days later. So that's the acute ischemic stroke related to atrial fibrillation. So there are the early treatment is better, later treatment, you can see this forest graph is showing actually there is not much of a difference. Slightly later treatment is better. That's what there is no major safety issues. Atrial initiation can be done early, safely, and the outcome is studied within 30 days, the primary outcome events. So as for that, now we'll switch to secondary stroke prevention long term. So whatever we have seen are on acute stage, DAPT and ELAN trial, acute and atrial fibrillation. Now we'll go on to the long term things. So secondary prevention long term. So most important is risk factor management, which I'm going to talk in the end. The lifestyle modifications, regular blood pressure monitoring, lipid control, what are the recommendations, adherence to antithrombotic therapy, patient education, counseling on diet, exercise, and smoking, a coordinated care plan involving neurologists, primary care physician, other healthcare providers ensures comprehensive management. So Sprint India study is from India, and Jairaj Pandian is a coordinator for the study, and we have all participated in this multi-center randomized control trial. So a structured semi-interactive stroke prevention package did not reduce vascular events when compared with standard. However, there was an improvement in some lifestyle behavioral factors, including adherence to medication, which might have long-term benefits. There was a possibility of type 2 error owing to the reduced power, since there were fewer events, higher number of patients could not be followed up. But This has taught us how to follow up, how to emphasize adherence to the treatments and adherence to the uh, avoidance of stroke risk factors. So, secondary stroke prevention, atrial fibrillation, the important aspect is you have to risk stratify, mild, moderate, severe, and NOVAC selection, renal assessment, and patient education. So these are important aspects. So it's a significant factor for stroke recurrence, atrial fibrillation, low atrial fibrillation. The initiation of anticoagulation after stroke is crucial. Balancing the benefits of anticoagulation with the risk of bleeding is essential. NOVACs have good efficacy and safety profiles. So all Relay trial, Rocket trial, Aristotle, Engage, all these trials have shown they all favor NOVACs. So more and more uh, patients are being, but cost is a limiting factor in some of these NOVACs are preferred. If suppose, even if then the stroke is not getting controlled, then we have to close the left atrial appendage by percutaneous methods in atrial fibrillation. And the recent study is these are Protect AF, JAMA 2014, Prevail, PROG. These are the studies in patients with atrial fibrillation, a moderate to high risk of stroke. That is chance VAS score of more than 2 and a contraindication to long-term oral anticoagulation due to a non-reversible cause. Percutaneous left atrial appendage occlusion is a reasonable recommendation. So a moderate to higher risk of stroke and higher risk of major bleeding, reasonable alternative is the occlusion to oral anticoagulation when it is not to be given with careful consideration. So these are the important studies that dealt with Plato. Now we'll go on to small vessel vascular disease, which we partly studied about the stuttering strokes. But here we see these are about responsible for 80% of intercerebral hemorrhages also. You can see the hypertensive arteriopathies and involving the lenticular striate branches and cerebral amyloid angiopathy. These are all small vessel vascular diseases. Antiplatelet therapy with aspirin or clopidogrel is generally recommended for lacunar infarcts. But the role of more aggressive antithrombotic therapy is less clear. But what is the drug that is most studied? Cilostazol. So these are the stroke which you see, and we don't know what is the major pathophysiology. It's a complex and not completely understood, and endothelial dysfunction, blood-brain barrier dysfunction, vessel stiffening, dysfunctional cerebral blood flow, ischemia, inflammation, myelin damage, white matter rarefaction, secondary neurodegeneration. So this is a proposed mechanism for the lacunar infarcts, and the rigorous blood pressure control is paramount important. Lifestyle modifications, dietary changes, and regular physical activity. Typically, first-line treatment is antiplatelets. The combination of aspirin and clopidogrel for long-term secondary prevention after lacunar stroke increases the risk of hemorrhage relative to either agent alone and is not recommended. But you see, cardiologists give for longer time. But when a stroke happens, lacunar stroke, please don't give for longer time, and we'll stick to that recommendation of 10 to 21 days. The one important drug that has been studied is cilostazol, which does platelet inhibition, vasodilatation, endothelial injury repair, smooth muscle anti-proliferative effect, anti-inflammatory effect in patient ischemic stroke related small vessel disease. The usefulness of cilostazol for secondary stroke prevention is uncertain, and we have some evidence, but it's not 3.4% versus 5.8%. Relative risk reduction is 41%, which is a p-value that is significant. So that was a 2000 study. And so there is a slight benefit, but there is a hemorrhage complication also. So you have to be very conscious. See the CSPS trial, which is published in 2019, the Japanese trial and 925 patients. The stroke recurrence is 2.6% when cilostazol with aspirin versus clopidogrel versus aspirin and clopidogrel. So it has shown very good prevention. Cilostazol, one thing which we have. So small vessel vascular pathology, modifiers of endothelial function can be used, and you can see now isosorbide mononitrate has entered. This is the LACIT trial, which is a JAMA 2023, the lacunar stroke, median stroke to enrollment is 76 days. and about 363 patients have been studied, which they have used a combination of isosorbide mononitrate 40 to 60 milligrams per day, silostazole 200 milligrams per day, or isosorbide mononitrate, or silostazole alone, or none. So the isosorbide mononitrate decreased recurrent stroke, odds ratio of 0.23, cognitive impairment also decreased 0.55, and dependence hello, ma'am. Hello. Good evening. Madam, Poli. Hello. Uh, ma'am, anything urgent? I'm in a class. I'll call you up sometime. Huh? I'll call half an hour later. Okay, thank you. So dependence, but what is important to notice that ICMN plus, that is isosorbide mononitrate silostazole, it decreased the combination, decreased vascular events and decreased cognitive impairment also. So it's a wonderful study and which has appeared. So now we can start using for small vessel vascular disease the modifiers of endothelial function, and there is a lot of recommendation, and the results are very impressive with this study, and you can read up that study later. So now we'll go to the next. Cervical artery dissection also gives rise to ischemic strokes, recurrent strokes. It accounts for about 2% of ischemic strokes, and up to 25% in young adults, cervical artery dissection is to be considered. Challenging diagnosis due to low sensitivity and specificity of imaging hallmarks. It's influenced by vascular comorbidities, environmental triggers, and anatomical genetic factors. The highest recurrence rate is in the first 2 to 4 weeks post-diagnosis. There are conflicting data on best antithrombotic regime for secondary prevention, anticoagulation versus antiplatelets. So this is CADIS trial and JAMA 2019, Treat CAD Lancet 2021. The endovascular intervention may be considered in selected cases. So that's the recommendation. We'll see what are the things that we should know. And this is the intramural hematoma, the carotid ring sign, suboccipital ring sign. These are all the diagnostic challenges for the radiologist and neurologist. Antiplatelet agents or antiplatelet, what is to be given. Optimal duration is not well established. Pseudoaneurysm formation or recurrent dissection, these are the risks. So regular follow-up is essential. And so occlusive dissection and lower ischemic stroke risk with anticoagulation. So whenever you have a high risk occlusive dissection, and then you should use anticoagulation. So now this STOP CAD study, international observational retrospective study, which has got about 3,636 patients with non-traumatic cervical artery dissection, studied the anticoagulation versus antiplatelets, and the Kaplan-Meier curves have shown that the recurrence, the survival is better with anticoagulation. So intracranial atherosclerotic disease is the next one, but we'll see. We have so this higher risk of major hemorrhage by 6 months with anticoagulation, that's the thing which you have to come. But there is no significant difference in ischemic stroke risk by day 30 with anticoagulation versus antiplatelet. But there is a subset of patients where high risk category you can use anticoagulation, but you have to be very careful. Then comes the intracranial atherosclerotic disease, 10% of all ischemic strokes. There's a high rate of early stroke recurrence, 5% at 30 days, 15% at 1 year. Severity of lumen stenosis is a strong predictor of the stroke risk. 1 year rates are as high as 18%, and in with more than 70% stenosis with the VASIT trial. And 25% had new infarcts in the territory of the affected vessel on brain MRI at 6 to 8 weeks. This is studied in Myriad trial on 2021. There are multiple mechanisms of cerebral ischemia in ICAD, and stroke on TIA, moderate to high grade stenosis. So this study is a very, very important study, which VASIT trial, but VASIT trial had shown warfarin is no difference in primary endpoints and higher rate of hemorrhages. So this VASIT trial has said warfarin need not be used for this, and you should use only aspirin. The 1,300 milligrams dose has been used here. Then comes the Sampris, superior to high risk of early stroke after percutaneous, preventing recurrent stroke in intracranial stenosis study. And the BMT, that is best medical therapy, is superior to percutaneous angioplasty and stenting. However, high risk of early stroke after the percutaneous intervention, and BMT risk of stroke is lower than the expert. So that recommendation is about best medical therapy. But things have changed since the time of 2011, which was published in NEJM Sampris trial. And now, because we know more and more about the usefulness of cilostazol in ICAD, and there are many studies that have come. The most important, the guidelines in patients with stroke or TIA caused by ICAD, more than 50%, aspirin is recommended in preference to warfarin to reduce the risk of recurrent ischemic stroke. Severe ICAD, addition of clopidogrel to aspirin up to 90 days is recommended in Sampris, actually. That's the basis. In patients with a minor stroke or high TIA and concomitant ipsilateral, more than 30% of stenosis of major intracranial artery, addition of ticagrelor 90 BID to aspirin for up to 30 days. So in India, we are all studying now, let's say 50% to 99% stenosis of major intracranial artery, addition of cilostazol to aspirin or clopidogrel might be considered to reduce recurrent stroke risk. So the stenosis trial, which is underway in India, which we are all participating, is studying the dual antiplatelet therapy for 1 year in these cases of ICAD. And so intracranial atherosclerotic disease, a basis trial, which is published in JAMA 2024, it's an open label multi-center RCT in China for symptomatic ICAD. And that means 70 to 99% stenosis within 30 days. Look at this trial. This is the first clinical trial to demonstrate that endovascular treatment is superior to medical management for secondary prevention of stroke in patients with symptomatic ICAD. So aggressive medical management group is compared with balloon angioplasty group. You can see the difference here, and that difference is significant. And the hazard ratio is 0.32 with a favorable confidence interval, and statistically significant difference is shown. So this is the first clinical trial that basis trial has demonstrated. So balloon angioplasty plus aggressive medical management statistically significantly lowered the risk of a composite outcome of any stroke or death within 30 days, or an ischemic stroke after 30 days through 12 months. So we suggest that balloon angioplasty plus aggressive medical management may be effective treatment for symptomatic ICAD, although the risk of stroke or death within 30 days of balloon angioplasty is a consideration. So you have to take this decision with the patient or discuss all the possibilities, then only you can recommend. Otherwise, just go ahead with dual antiplatelet therapy 1 year. So what do we have? Angioplasty with stenting. There are no RCTs have demonstrated benefits with higher rates of strokes and death reported compared to medical management in angioplasty. There may be extracranial intracranial bypass. Direct bypass failed to show any result in COST 2011 and CMOS 2023 trials. Indirect bypass study is ongoing study. The antithrombotic therapy has been studied in VASID and Sampris. High-dose statins and lipid-lowering medications, targeted risk factors control, healthy lifestyle. The best antithrombotic regime is being studied in this study called Captiva. This is an ongoing study. The primary goal of a Captiva trial is to determine whether rivaroxaban or ticagrelor or both are superior to clopidogrel in reducing the primary endpoint, which includes ischemic stroke, ICH, or vascular death within 12 months for patients with 70 to 99% of symptomatic ICAD. The trial aims to enroll up to 1,683 participants over a 4-year period, with enrollment commencing in August 22. So that is ICAD. Now ECAD, extracranial artery disease, atherosclerotic disease, represents about 10 to 20% of all ischemic strokes associated with advanced age, male sex, and traditional vascular risk factors. Risk of stroke is limited to degree of lumen stenosis and block instability. And carotid artery stenosis is, you can see in all these pictures where carotid artery stenosis is seen. ECAT in patients with TIA, recent TIA or non-disabling stroke, ipsilateral severe carotid stenosis, 70 to 99% class 1A evidence is carotid endarterectomy and provided perioperative mortality is less than 6%. Moderate carotid stenosis, 50 to 69% and class 1, and that is CEA, less than 6% of the perioperative mortality. Age, sex, and comorbidities are to be taken into consideration. If poor surgical risks, then class 2B recommendation is for carotid stenting. Intensive medical therapy with antiplatelets, lipid-lowering therapy, and antihypertensives might reduce the stenosis. Well, all these studies which are recommended, all these, they were studied in NACET and the ECAS. They were studied when these intensive medical therapy regimes are not available. So antithrombotic management in patients with undergoing carotid revascularization, carotid endarterectomy, SAPT, aspirin 81 to 325 before CEA and continued indefinitely post-operatively. If it is stenting before and for a minimum of 30 days after CAS, DAPT, aspirin plus clopidogrel is recommended. Nowadays, people are using ticagrelor. So transesophageal echocardiogram of aortic arch, you can see no advantage of warfarin, no compelling evidence for DAPT for aortic arch-related cerebral hazard trial, and that trial is ECARD. Aortic arch atherosclerosis has been studied in ARCH trial, which is a transesophageal echocardiogram has been shown here. There is no advantage of warfarin, no compelling evidence for DAPT. Minor strokes that meet point criteria should be treated with short-term aspirin plus clopidogrel, and LDL should be kept less than 70 by various means. You should keep it less than 70. So this is the ARCH study, which is published recently in 2014, about a decade back. Then the embolic stroke of unknown source. It's a subset of cryptogenic strokes, represents about 17% of all first-ever ischemic strokes. Affects a relatively younger population. It generally manifests with milder symptoms. It has a recurrence rate of 4 to 5%. So all the secondary preventive strategies have to be applied. The MRI, non-lacunar embolic stroke, no LVO, more than 50% stenosis. That means no atrial fibrillation or other cardioembolic source or specific cause. So large vessel occlusion is defined by more than 50% of the stenosis. So what are the studies that have come? That is Navigate ESUS, rivaroxaban versus aspirin that appeared in 2018 in EJM. Respect ESUS, dabigatran versus aspirin. No reduction in secondary stroke risk. So there is no benefit in patients with ESUS. Treatment with direct DOACs is not recommended to reduce the risk of secondary stroke. So only we use aspirin. There is no DOACs in ESUS. Now, Arcadia trial is there's a hypothesis that apixaban is superior to aspirin for prevention of recurrent stroke in subjects with atrial cardiopathy, cryptogenic ischemic stroke, and where atrial cardiopathy is defined as one of the following markers. The P wave on ECG terminal falls more than 500 millivolts in ECG lead 1. The pro BNP more than 250. Left atrial diameter index 3 centimeters or more on echocardiogram. Recurrent stroke of any type is being studied, and safety concerns of ICH, intracranial or outside, are being studied in this study. So we await the results to give the recommendation. Now that finishes our ischemic stroke. Now we go on to the intracerebral hemorrhage, and hematoma expansion is a very common thing, the powerful predictor of poor outcome. 20 to 40% of patients presenting within 3 hours, they show hematoma expansion, potentially modifiable key treatment target. There are many signs: spot sign, black hole sign, blend sign, island sign, swirl sign. These are all indicators that hematoma is going to expand. So there are now, if you limit hematoma expansion is the first. To do that, you have to reduce the blood pressure reduction. And interact 2 study and attach 2 study, post hoc analysis showed BP reduction in less than 2 hours was linked to less hematoma expansion and better outcomes. What we have is interact 3, which I want to talk later. Then we have hemostatic therapy, that is recombinant factor 7A, FAST trial in 2008, Spotlight, Stop It in 2019. The FAST post hoc analysis showed that early treatment within 2.5 hours reduced hematoma expansion and suggested better outcomes. There is a fastest trial which is ongoing. In India, we are all participating in intrinsic trial with tranexamic acid, and did also post-hoc analysis of these trials, which are published, showed that early treatment was linked to better outcomes. So we're also doing this within 4 hours of our onset of ICH. Vitamin K antagonist, then anticoagulation reverse. Then vitamin K antagonist, that is prothrombin concentrates better than the fresh virgin plasma. Direct thrombin inhibitors, that edosimab, and 10A inhibitors antagonists, that adenosine alpha. So these are the things which are available, but we don't have all that. We have PCC now. So ICP management is very important, and reduce ICH volume, mass effect, and ICH related. So one of the important studies that have come, which has shown some first time, the ENRICH trial, which is published in 2024, which is a multi-center RCT comparing minimally invasive parafascicular surgery to medical treatment for lobar ICH 30 to 80 ml within 24 hours. This is the first clinical trial which demonstrated a functional benefit of hematoma evacuation in patients with supratentorial ICH, particularly in lobar ICH cases. So it's a large study, and it is improved utility weighted modified Rankin scale at 6 months, and substantial clot evacuation, and decreased ICU hospital stay. So you remember the ENRICH trial is the first trial that has proven very effective, that you should see. Then what is the Interact 3 trial said? The Interact 3 trial, this international stepped wedge trial, cluster randomized control trial, and almost 7,000 patients with spontaneous ICH less than 6 hours of onset across 121 hospitals studied. One is usual care. The other one is goal-directed care bundle. That is intensive BP control, systolic blood pressure less than 140, lower threshold is 130, strict glucose control, no diabetes. It should be around 110 to 140, diabetes 140 to 180. Anti-pyrexia treatment, target body temperature less than 37, anticoagulation reversal with warfarin, the PCCs. So the key outcomes showed reduced unfavorable functional outcome, earlier discharge, and lower mortality at 6 months. So the treatment initiated within 1 hour and maintained for 7 days. So this is what the Interact. So that is a very encouraging sign that now the goal-directed care bundle approach has come for ICH cases. Similarly, in India, we are studying what is called FRESH trial, fever, swallowing, and glucose control and hypertension control. In first 72 hours of all the strokes, if you take care of these factors, the outcomes are much better. Vascular risk factors, we'll briefly just skip over them. There are 7 life simple factors: hypertension, diabetes, hyperlipidemia, overweight, obesity, physical inactivity, diet and nutrition, cigarette smoking, obstructive sleep apnea. These are all modifiable. The age, gender, race, it's hereditary. These are all non-modifiable. So there are various recommendations, and history of ischemic stroke, recent acute coronary syndrome, history of MI, symptomatic peripheral artery disease. These are all high risk cases, and these are very high risk for future vascular events. High risk conditions: age is more than 65 years, heterozygous familial hypercholesterolemia, history of cabbage, and percutaneous coronary intervention, and diabetes, hypertension, chronic kidney disease with a GFR of 15 to 59, and current smoking. These are all very high risk patients. So there are goals of set for hypertension, and everybody knows, and I'm not going to touch about that. You can see and just point yourself what you want. But the important thing in ischemic stroke is don't tamper with the blood pressure unless it is very high. In case of hypertension, second and ICH, bring it down to less than 140/90. Then the HbA1c should be less than 7% and start with metformin. And you should see that LDL is more than less than 70, and it is reasonable to use the pro-protein convertase in sertalism Kexin type inhibitors, that is Repatha and all, if LDL is not coming down with your other methods like statin, ezetimibe, and bempedoic acid and other things, then you can start using those and bring down the LDL less than 70. That's very important. And also smoking. Smoking is very important, and you should recommend avoidance of smoking is very, very important. You help in all the possible ways to stop smoking. And of course, the patients with ischemic stroke, TIA, plus obstructive sleep apnea, treatment with positive airway pressure can be beneficial for improved sleep, BP, sleepiness, and other apnea-related outcomes. So these may be considered for diagnosing sleep apnea with polysomnography. You have to go for post-stroke cases. We should take up a study, and not many studies are there from India. So vascular risk factor management, the guidelines have been the sleep smart. But the sleep also is very important in post-stroke survivors. So we have to do sleep tests. Then physical activity, moderate intensity aerobic activity for a minimum of 10 minutes, 4 times a week, or vigorous intense activity, 20 minutes per twice a week. Very important. And physical exercise. And this year's stroke awareness program said that everybody should pick up a stroke or whether a sport so that they can indulge in this type of vigorous activity. And that is the slogan of this year's World Stroke Day. The diet, patients with stroke and head recommendations to follow Mediterranean diet, emphasis on mono unsaturated fat, plant-based foods, fish consumption, either high extra virgin olive oil or nut supplementation, in preference to a low-fat diet to reduce the risk of recurrent stroke. Hypertension not currently restricted in the dietary sodium, reasonable to recommend reduce sodium by 1 gram per day, that is 2.5 grams per day salt to reduce the risk of cardiovascular disease events. So that is the salt that's allowed. So vascular risk factor management has definitely reduced. The rates have declined over 50 years, mainly due to improved blood pressure control and more frequent antiplatelet use, as shown in these graphs. So I conclude by saying that TIA and acute ischemic stroke risk of recurrence is dependent on etiology. Prevention strategies depend on the subtype of stroke or TIA. DAPT reduces the rate of early stroke recurrence in acute phase, those arriving early with minor acute ischemic stroke and higher risk TIA or with severe symptomatic ICAT. There are some new antiplatelet agents with a lot of promise, ticagrelor, and antiplatelet monotherapy rather than anticoagulation is recommended for long-term secondary prevention of non-cardioembolic stroke. Antithrombotic agents are only one part of a comprehensive risk factor management strategy. Management of vascular risk factors, including hypertension, diabetes, smoking, cessation, lipids, and lifestyle modification are very important. Enrich and Interact 3 trials showed a ray of hope for ICH cases, which is a great thing. So I conclude by saying that emerging evidence supports optimizing antithrombotic regimes in the acute phase for mild strokes to reduce the high early risk of recurrence, which is much more with atherosclerotic related conditions. Selecting the most appropriate secondary ischemic stroke prevention strategies relies on understanding the injury mechanisms, with new studies informing management of strokes with specific causes. ICH remains a critical emergency with high morbidity and mortality. Minimally invasive early hematoma evacuation shows promise for selected patients. Goal-oriented care approach, which I showed in Interact 3 trial, can enhance outcomes for a broader patient population. That's all from secondary stroke prevention. Thank you very much. If there are any questions, you can now ask. Any questions? So just go through all these studies which I mentioned. These are the latest studies which are useful for the exam going students. They should revise all these studies and get updated so that recent advances paper, it's very beneficial. Okay, if there are no questions, then we'll stop here.
Thank you, sir.
Welcome.